Namaskar to all MOS and non-MOS members who have logged in for this very interesting webinar on a subject which is not only close to my heart but close to the hearts of all the people who have assembled on this platform today, particularly the speakers, the moderators. So it's a huge pleasure to be here today in a webinar on strabismus, which I love, of course. And before I ask Nikhil to introduce the speakers, I'd like to introduce Dr. Parikshit Gopte, who is the first Vice President of MOS and who's with us today and will be with us from henceforth. Over to you, Nikhil.
Yeah. Good evening, ladies and gentlemen. It's a pleasure to be here. And with this stellar sort of a cast that we have for this program, I am going to start by introducing two of the speakers, Dr. Jitendra Jathani and Dr. Kavita Kalaivani. So I'll start with Dr. Jitendra. So as I was going through it, it's a massive CV that he has. So as I was just discussing, it's really impossible to go through all of it. So many are his achievements. We know Dr. Jitendra in our pediatric circles since a very long time. And it's a pleasure to have you here, Dr. Jitendra. So he's one of our leaders, I would say, in research, academics, some brilliant papers that he keeps coming up with. And so he's doing pediatric ophthalmology at least for 18 years or 20 years, I suppose. I'm sure, isn't it, Dr. Jitendra? And now he's got a number of awards, out of which I'll just mention the Athavale Award, the Raghudeep Film Award, ICO Travel Grant, Hanumant Reddy Award, IIRCI Gold Medal, goes on and on and on. Pata nahi itna sab ab rakhte kahan ho, Jitendra ji. So it's a pleasure to have you here. I'm sure we are all going to be enlightened. We'll be more knowledgeable at the end of your talk. With that, I welcome you and come to Dr. Kavita Kalaivani. It's a pleasure to have you here, ma'am. We know that she's a senior consultant in pediatric ophthalmology and neuro-ophthalmology at Shankar Nethralaya and has special interest in pediatric neuro-ophthalm, adult strabismus, surgical management of nerve palsies, traumatic cataract, adult cataract, you name it, and she's doing it, and I'm sure in a brilliant way. And responsibly, she's teaching a lot of optometry students, postgraduate teaching, cataract surgical training for FACO, and she's part of the NABH team. She has a special experience in using Botox for conditions like facial spasms and nerve palsies. I'm sure that is going to be an interesting thing that we can discuss at the end of the show. So welcome to both of these opening batsmen, I would call them probably. And on to Dr. Snehal for introducing our stalwarts, second stalwarts, I would say.
Okay, good evening, everyone. So with immense pleasure, I introduce Dr. Suma Ganesh, who is presently the Deputy Medical Director, Chairperson and Head of Pediatric Ophthalmology, Strabismus and Neuro-Ophthalmology at the Shroff's Charity Eye Hospital, Delhi. She has done a fellowship in Pediatric Ophthalmology at the Manhattan Eye and Ear Hospital in 2001 under the Orbis Fellowships. She also has been awarded the SD Athavale Award and for the best paper in Squint in 2003. And she has also received the prestigious Ecoin Award in 2012 for her work in strabismus in the community. As you can see, she is very passionate about pediatric ophthalmology and has been involved in a lot of childhood blindness projects like Hand in Hand, Sight Saving Project and Refractive Error Project with Orbis and many others. She has also trained many pediatric ophthalmologists through the various POLTC projects, like nationally as well as internationally. And she has many national and international conferences and 88 publications to her credit. Thank you, ma'am, for accepting our invitation, and we welcome you for the webinar today. And now I introduce the force behind all these successful MOS webinars, Dr. Sunaina Malik, a teacher par excellence, an excellent squint surgeon, and a born leader. She has learned and practiced strabismus and building up her base slowly right from her undergraduate and postgraduate days at GMC Nagpur, and her teaching posts at VM Medical College Solapur, GMC Aurangabad, Nanded, and of course MGM Medical College Aurangabad. She is particularly passionate about amblyopia management, and she's also one of the first contact lens practitioners in Marathwada region. She has received the Best Teacher Award in MOS, and she has been the Secretary of MOS, has been the Chairperson Scientific Committee, and she is the present President of the MOS. And these are just a few of her achievements. So thank you, ma'am, for organizing this webinar, and we are waiting to listen to you. Thank you.
Parikshit, can I ask you to introduce our two wonderful moderators, please?
Yes, thank you, Professor Sunana ma'am, for having and conceiving this webinar on strabismus. You're something that's been close to your heart in MOS for many, many years. Well, we have two young, young only, we should say, looking at us, ma'am, moderators. But then we have Professor Snehal Thakre. Yes, she's a full professor, and she has done her training first at the Rural Medical College, Pravara, and later at LV Prasad Eye Institute, Hyderabad. And she has her subspecialty in pediatric ophthalmology and strabismus. And of course, as a full professor, she has been training numerous students, has been supervising them, and she's the one who has been the anchor for taking this webinar forward. And second one is, of course, my friend, Dr. Nikhil Rishikeshi, who is another pediatric ophthalmology, who heads the famous pediatric ophthalmology and strabismology department at HV Desai Eye Hospital. He's also done his training at the All India Institute of Medical Sciences and the Birmingham Children's Hospital. And I think he can be justly called as a person whose fellowship is perhaps the most sought after pediatric ophthalmology fellowship in Maharashtra at this point of time. So, well, congratulations for that, Dr. Nikhil.
Thank you.
And I'm sure both of you have worked hard in getting all the speakers together. So, well, over to you, and we look forward to hearing all these knowledgeable speakers in pediatric ophthalmology.
Thank you so
much. Thank you so much, Parikshit, for introducing our two moderators. So now, without further ado, I think we'll begin the webinar. So I would request Dr. Kavita to please start sharing her screen. She's our first speaker.
Ma'am, please unmute yourself. Please unmute yourself.
Unmute yourself.
Sorry, am I unmuted? Am I audible?
Yes,
yep.
Yes. Yes.
Yes, you're audible, ma'am.
Thank you. I first thank Professor Sunaina ma'am for inviting me. And this is a great privilege, I feel, to be part of MOS program. This is the first for me to be part of this program and to share the podium with the great speakers. So try to go into, see, as like all of us here are really passionate about pediatric ophthalmology and especially strabismus. So when it comes to strabismus, this is how the other ophthalmologists and we are different. I keep telling my PGs and fellows that we see the eyes as a unit together, whereas all other specialties, most of the other conditions involve the eye as a single unit, like they take care of each eye most of the time separately, but whereas we go beyond that and we look at the eye as a working unit, as an eye is a together unit. So when you face a situation where you have a child or an adult with a strabismus, how you make it simple and how you examine a child. So from the beginning to the end, what is the order and how do we examine? So examination starts. So what are the challenges we face, especially in pediatric strabismus? So first and foremost is limited cooperation because mostly of their age. So children do not come to the hospital voluntarily like adults. So they have all the reasons not to be really cooperative. So that is the first challenge all of us face. And many times young children, they do not have a subjective response. They don't tell us what the problem they face. So we have to pick up the problems that they might be facing because of strabismus. And so you need time. It is a patient, time-consuming process when you examine a child with strabismus. So these are the challenges. So before you even start to examine, whom do we suspect to have problems of strabismus? So beware of children at risk. So any child born of a consanguineous marriage, any positive family history, prematurity, cerebral palsy, all these children may be at a slightly higher risk of having strabismus compared to other children. So when it comes to history, we need to have a detailed history of the presenting complaints. A birth history is very important. Like I said, prematurity can be associated with higher incidence of strabismus, a positive family history, and history of any previous treatment when they come present to us before coming here, if they have had surgeries or glasses or any exercises or anything. So then once you have all this, then we go into examination. So how do you start examining a child. So when you start the child entering the room itself, you start looking for any abnormal head posture, any shaking of the eyes, squeezing of the eyes. Many times, a lot of things are given away as the child walks into our OPD. So we have to observe as soon as we see the child entering the OPD and look for and ask for vision problems, if any. So how to examine? So there is an order which most of us follow to not miss important findings. So how do we examine? It's vision testing. So we use age-appropriate vision testing protocols. So like unlike in adults where a standard vision testing is possible, in children we have to have vision testing as per age. So we won't go into the details today because we'll go into strabismus evaluation part. So vision testing as per age. And refraction, of course, because many of the strabismus entities and refraction are directly linked together. And then assessment of binocular vision, assessment of the strabismus as such, and a detailed ophthalmic examination to see if there is any other association. So what do we really need? What is the armamentarium of a strabismologist? It's really, really very simple. All we need is a good trial frame set, a few strabismus stereopsis chart, Worth 4-dot torch, prisms. So we don't need exotic equipments and scans and things like all other ophthalmologists might be requiring. All we need is a lot of patience and a few nice toys and just this. So ideal order after we know the vision, especially in the second or third visit, when we know the vision status, best is first to do a sensory evaluation. Why? Because whenever a child has intermittent squint, for example, they may have fusion mechanism which is not really, which may be labile fusion, maybe they may have a fusion which is easily interrupted. So when we check vision, we check uniocularly. So before we even do a vision checking, ideally, at least after the second or third visits, when we know the vision is good or when we know the vision status, best order is to do a sensory evaluation before we even break the fusion. So sensory evaluation is divided into two parts. One is stereopsis evaluation and next one is fusion. So stereopsis, for our practice, we use basic 2-3 consistent stereopsis examination techniques where we are sure to know what exactly we are looking for. So most of these measure stereopsis in the range of around 40 to 80 arc seconds to a gross stereopsis of 3000 arc seconds. So some of these like Randot and Titmus require the children to wear Polaroid glasses or red-green goggles, and they are asked to identify. So you give a gross stereopsis like the B first, and then you go to a grades of stereopsis. So you can find out the range of stereopsis. But all these tests which are clinically, actually practically used are only for near stereopsis. Rarely in practical clinical practice, routinely, distance stereopsis is seldom used. But ideally, yes, to evaluate a strabismus, a thorough distance stereopsis as well is required. But at least a basic near stereopsis is important. So this is how we do. If a child is having glasses, you have to make the child wear his own glasses. And we are doing a Randot test. So he has to have a good lighting and wear the Polaroid glasses, and you have to explain, ask for and look for what they are identifying. So next is once you do a stereopsis test, then we do a test for fusion. The commonest test performed in OPD is the Worth 4-dot test. It's a very useful test. It gives you lots and lots of information. Again, you need the child to be wearing the glasses, which cannot be overemphasized. In his refractive correction, we have to do these sensory evaluations. So they wear red-green goggles, and then you have to ask them to see the dots and identify how many dots of what colors they see. So distance as well as near Worth 4-dot test has to be done because distance measures only the central fusion, whereas near Worth 4-dot test measures the peripheral fusion. So sometimes in certain conditions, even if central fusion is not present, they can have peripheral fusion, which is a very good information when we are looking at, especially post-surgery, after you do a surgery, when we evaluate a patient, if distance fusion is not there, but near fusion is present, it is actually a good sign. It is a sign of improvement. So we have to do both. So how do we interpret a Worth 4-dot test? So if they have a binocular single vision or an anomalous retinal correspondence, so they see 4 dots, of which 2 is green, 1 is red, and 1 is yellow. If there is a right eye suppression, when they are wearing the red goggle in the right eye, they see 3 green dots. If left eye is suppressed, they see only two red dots. And if they have a binocular diplopia, then they see 5 dots, of which 3 is green and 2 is red. Sometimes they confuse the colors and confuse the numbers. In that case, the test is probably not really reliable. So you have a sensory evaluation and you know the stereopsis status and you know the fusion status. The most second important thing is to see what actual type of strabismus they have, which is called motor evaluation. So motor evaluation, you again classify it into qualitative assessment and then quantitative assessment. First, we know what the child has or the adult has, and then you see how much they have. So how do we do a qualitative assessment? So here again, there are 3 basic types of tests that we perform. The commonest is cover, uncover test. It's a very, very important, a simple test, but extremely useful test. And it's like a weapon for strabismologists. So the first test is cover, uncover test. So this test tells us whether a patient has a phoria, which is called a latent strabismus, or a manifest strabismus, which is tropia. And then once you do a cover uncover test, then you do an alternate cover test. Alternate cover test gives us 2 information: how the total deviation likely to be, and whether a patient has a preference for a particular eye. Especially when we talk about preference, even if a patient has equal vision in the presence of a strabismus, they may have one dominant eye. So this is important later on when we plan a surgery. So we want to plan a surgery on a non-dominant eye. So eye preference is also a test, a finding which we get out of an alternate cover test. So what do we do when we do a cover uncover test? So which eye do we cover? So in case of a patient who has a clear large strabismus, and you ask the patient to look at the distance chart. So if the patient is looking at with one eye clearly, when you are sure that there is a strabismus, then you cover the fixing eye. Otherwise, when there is orthophoria, you cover either eye. And you always have to cover one eye, uncover it, see first what happens to the uncovered eye, and then see what happens after you remove the covered eye. So to do a cover test, what are the prerequisites? You can't do cover test probably in every situation. So first of all, you need some kind of a comprehension. The patient should have a little understanding of what really we are going to do. You can't immediately go and rush and put a hand on in front of the patient's eye. So there is some amount of comprehension required. And to do a distance cover test, we need the child or the adult to at least have 6/60 vision. At least they should be able to see the first line of the Snellen's chart. And the eye should be able to move, because cover test is based on how the eye moves to take up fixation. So ocular motility should be at least up to the midline. And what does the patient wear? Again, always refractive. If they already have a correction, they have to wear their correction. And what do you use to cover with? Ideally, an occluder. But sometimes in very young children, an occluder can actually be a little offensive. So you can indirectly come from behind and use even a thumb and even a palm. So whatever is you are comfortable and the patient friendly, you should use. So what happens step 1, what happens when you do a cover test? So you cover the fixing eye and then watch the other eye. Is there any movement? So what are we watching for is we want to see if there is any movement. So yes, if there is a movement, you want to see whether the eye moved in or out or up or down. So 2 things we find out by doing a cover test. We see whether there is a movement, and if there is a movement, whether the movement, what the direction of the movement is. So yes, when you have the cover test, you cover one eye and you see there is a movement, you conclude that there was a tropia or a manifest squint. So then if there is no movement, then here you can't just immediately do one cover test and just leave it. You have to really make sure. So you cover again and watch, and still there is no movement. Then you would go to step 2. So this is what is cover test. So you see a child, you use an occluder, you see a left eye deviating. So you cover the fixing eye, which was the right eye. And what is happening? The left eye is coming in to take a fixation. So you always repeat the cover test in both eyes as well as distance and near. So here, if you watch this video again, So you cover the right eye, left eye is out, so it comes in. So you know that there was an exotropia. So you are confirming it. Now you cover the other eye and see what happens. That right eye is not moving. So probably this child has a left exotropia. It is not a really alternating exotropia. So these two things we are able to make out. So this is for distance. And we have to do the same test, repeated for near. Always distance and near. And when we do a near cover uncover test, we should not use a torchlight. We have to use an accommodative target. We have to use some target which has some details in it. A near Snellen's chart you can use, or some with like a picture stick. So again, you watch for what happens, whether there is a tropia and whether there is free alternation or preference for one eye. So step 2. So when we find the tropia, then you go to the step 2. You watch what happens to the uncovered eye. So you remove the cover and see under the cover what happened to the uncovered eye. Is there any movement? Yes. So if there was no movement in the cover test of the other eye, but when you uncover, you find a movement of the eye which had just been covered and opened, and the eye moves in or out or up or down, then you know that there is a phoria. It is a latent squint. So with the cover uncover test, you find whether there is a phoria or a tropia. So when you know there is a phoria or a tropia, you know whether there is a hyper, hypo, or exo or esotropia. So doing this cover uncover test, you have got this much information. So now we want to know how much they have, right? So after the qualitatively you knew what the squint is. Now you want to know how much they have to decide how to manage it. So here comes the tests which quantify the strabismus for us. So commonest is corneal reflex test based on reflex of the cornea, prism tests, which is the gold standard, and finally synaptophore, which kind of gives you a collective picture of all the information that we need. So how do we interpret a Hirschberg test? So we see nicely here, left eye in the first picture, the left eye, the corneal reflex is exactly at the center, but right eye, it is shifted towards the limbus. So when the light reflex is towards the limbus, it implies that the eye is towards the opposite side. So with Hirschberg, we know again there is whether the eye is hypotropia, exotropia, esotropia, and we can, based on the position of the reflex, how much it is deviated from the pupil and limbus, we can even quantify how much it is. So this test is a very common, simple test which can be done in OPD by anybody. So it is called the Hirschberg's test. So another corneal reflex test, which again is used to quantify strabismus. What is this test? This Krimsky's test. Again, we see this girl having in the first picture, Hirschberg showing a large exotropia. You see the corneal reflex in the left eye, left side in the first picture, showing the right eye almost in the sclera. So it's a very large deviation. And in this side, we try to neutralize the deviation by adding prisms. So Krimsky test is done. So you add prisms as much as needed so that the corneal reflex under the prism becomes central in both eyes. So this is again a very good, useful quantitative test, and this is called the Krimsky's test. So the third test, which is the commonest test and which is the gold standard that we always try to perform before we plan surgery, is the alternate prism cover test or prism bar cover test. So here we keep adding the prisms and wait for neutralization to happen. Neutralization is when there is no movement or when deviation reverses. So that is the end point. So you keep adding prism. Here you can see there is now no movement. And now if you really see, we have a small additional vertical prism. So sometimes this can happen when you keep measuring, expecting that there is one type of deviation, because many times deviations can coexist. A horizontal deviation can coexist with a small vertical deviation. So usually towards the end of neutralization of the larger deviation, we sometimes find the smaller deviation coming up. So you have to measure that also. So when you do a prism cover test, if you have normally loose prisms come with maximum size of 50 amount. So if you have a deviation which is more than 50, you can split the prism between the eyes and measure, but never stack horizontal prisms together or vertical prisms together. But if there is a horizontal and a vertical strabismus, you can add a horizontal prism above a vertical prism. Otherwise, if you stack horizontal prisms, the deviation what we get is not true and it is highly erroneous. So you can split same direction prisms, but you can stack a horizontal and a vertical prism. So similar to a distance alternate prism cover test, you always have to do a near alternate prism cover test. So this is another very nice, interesting test. It is called a simultaneous prism cover test. Here, especially this test is useful to detect only the tropia part. The alternate prism cover test gives us the total deviation. So, but here, especially after a surgery, sometimes you find a residual esotropia or exotropia, and you want to know how much of that residual deviation is within the fusional control and how much is not. So that sometimes you may want to do an additional management like to give a prism, etc. This test is very useful in that kind of a situation. So you place a cover and a prism simultaneously till neutralization. So this gives you only the tropia part. So finally, after you measure, then you need to do an ocular motility examination. So versions, and if you find versions to be limited, then you have to do uniocular reductions. And here a small point is when you do depression examination, you first let the eye depress and then lift the eyelid, otherwise there can be a false interpretation. So then once you have done all the sensory evaluation, motor evaluation, quantitative, qualitative evaluation, now you know what you're dealing with, the strabismus part. But every test is complete only with a full ophthalmic evaluation, which includes anterior segment evaluation, pupil evaluation, intraocular pressure whenever you have to do, and fundus examination. Sometimes fundus examination can help us in the strabismus evaluation by we can note torsions, intorsion, extorsion, which can be sometimes not really seen in a clinical strabismus evaluation, especially in small children. So fundus examination can actually help us in strabismus evaluation as well. So these are the common tests which are performed, but sometimes we need to perform some special tests, especially when we see a situation like this, which is an incomitant strabismus. So a very ideal tool is diplopia charting along with Hess charting. It is usually ordered when we see a nerve palsy. So here the trick is to interpret is the smaller chart is the problem with the paretic chart. And paresis and restrictive strabismus can also be detected. Here the ideal use of this test is you can single out muscles based on doing a good Hess charting. If you, ideally you yourself have to perform the test to the patient if you want to interpret it, and you can isolate muscles. So it is very helpful, especially when you do follow-up Hess charting in a nerve palsy patient to see the development of muscle sequelae. So smaller field is the paretic eye, and if it is neurogenic, largest underaction in the direction of the paretic muscle and largest overaction is seen in the contralateral synergist. So you see muscle sequelae based on Hess charting, serial Hess charting. And when it is a mechanical problem, then compressed field without obvious overaction is what we find in Hess charting. So this is another very interesting test called the Parts 3-step test. So here again, it is very useful in vertical strabismus, especially nerve palsies. So first is you see do cover test in primary gaze, then on right gaze and left gaze, and then on right head tilt and left head tilt. So here, based on which particular muscle is at fault, we interpret findings. So here, especially if you see in this patient, you have a neck collar. So this patient actually has a bilateral superior oblique palsy with bilateral inferior oblique overaction following a RTA. So Parkes 3-step test is a very useful test in case of vertical strabismus. And finally, a very, very important useful test is the force reduction test. So if we do this test to differentiate if there is a active, when you have a limitation of movement, when you do ocular motility test, to know whether the limitation is because of a paresis or a restriction, we do this test. So this test is done when the patient is either under topical anesthesia or under general anesthesia when the muscles are completely relaxed. So if there is resistance to passive duction, then you know that the positive force reduction test implies there is a mechanical restriction to the movement, whereas a negative force reduction test but limited motility implies a paresis. So I conclude by saying strabismus evaluation is an art that is learned by practice. Thank you for patient hearing. Thank you.
Thank you so much. Thank you so much, Dr. Kavita. That was a wonderful overview of how to examine a case of strabismus. I think even those who are not doing it will feel encouraged to do it now. I would now request Suma to please share her screen, and she's going to be talking to us on interesting esotropia cases.
Yes.
Suma, unmute yourself. Suma, we can't hear you.
Yeah, sorry. At the onset, I would like to thank Professor Sunaina Malik for inviting me for this interesting webinar. She's an inspiration to all of us. And also, I would like to thank my friends, Dr. Snehal and Dr. Nikhil, for inviting me and for the kind words of appreciation. I will be speaking on esotropia, interesting cases. So this is how we define, there is two types, comitant esodeviations and incomitant esodeviations. So comitant esodeviations are defined as accommodative esotropia, and we have the four types: refractive, non-refractive, partially accommodative, and hypoaccommodative. And the non-accommodative esotropia with infantile esotropia, basic esotropia, convergence excess, divergence paresis, cyclic esotropia, and the acute onset comitant esotropia. The incomitant esodeviations are mainly paralytic. They could be neurogenic, like the abducens palsy or the divergence paresis, or myogenic and restrictive, musculofacial duance or other restrictive conditions. Now, let us say a child is presenting with esotropia. So whenever the child presents, you need to know the age of onset, whether it started before the age of 6 months or what age it started, whether it is intermittent or constant, or whether it's more when focusing for near. It is important for us to evaluate the degree of hypermetropia. I would recommend that any child with esotropia, please perform atropine ointment refraction. I know there are contradictions in this, but at least once an examination by atropine, twice daily for 3 days, and getting the full hyperopic correction is always essential. So suppose if we have to plan surgery in such a case and we have not unlocked the full hyperopia, then we may land up later on into trouble. Or we could use, if the patient is from outstation, we could use cyclopentolate drops, 1% in older children, and then you perform the retinoscopy after 60 minutes. It is strongly recommended to prescribe spectacles at first if the hyperopia is greater or equal to plus 2.5. So this is a child with an inward deviation of left eye since 2 years of age, and the vision in the right eye is 6'9", 6'18", 30 prisms both for distance and near. Atropine refraction was done. He had a +4 in the right eye and the +5 in the left eye, and now we know because there's a difference of 1 diopter, there is amblyopia in the left eye. So we give the full cycloplegic refraction, repeat the vision after 2 months, and also the orthoptic evaluation. If the vision is less, then we need to start amblyopia treatment. So this is the refractive accommodative esotropia corrected totally with glasses. Now, parents' questions are, what happens to the child's number? What is the natural course? Because all are worried whether my child will continuously have to wear glasses. So there is a gradual reduction in hyperopic power, but I always tell parents that till 6 years of age, there may be an increase. And 6 to 8 years, it remains stable. And after 8 years, we ourselves start reducing the power. So when do we wean off? We start normally at the age of 8 years. I do not do it before 8 years, though books mention and papers mention by 6 to 7 years. I feel that in India, sometimes parents present to us very late, and so they already have low binocularity. So I would prefer to wean off only after the age of 8 years till we have stabilized the squint. What I find is that, and also in basic literature, we find that lower levels of baseline hyperopia, like if the child is presented with 3 diopters or 2.5 diopters, they were associated with higher success rates of weaning off. We could wean off those glasses. But the higher hyperopia, still we could wean off around 2.5. So the parents are happy if they're told that the number will reduce. And any single reduction should be limited to 0.75 or 1 diopter. So if we find that the deviation, we have given the glasses and still it is not fully corrected with glasses. So here is a child, we have again with the glasses, we have around 15 to 20 remaining behind. And this is known as partially accommodative esotropia. And what are the risk factors for decompensation? That is why we need to follow up all cases of accommodative esotropia. We can't just leave them. So suppose we find that they are presented at a younger age, very high hyperopia, like more than 5, or it's a child with a high AC by ratio, or there's amblyopia. We need to rigorously follow them up because these are the children who will deteriorate into partially accommodative esotropia. And then we need to treat them. The non-accommodative part should be corrected by surgery. The bimedial rectus recession is the treatment of choice. And we should tell parents that they will need glasses even after surgery. We are not doing surgery to remove the glasses, but we are only correcting the squint which is present with the glasses. Now, suppose if we have, again, if we have another entity where there's a distance and near disparity. So when you measure for distance and near, you get that the distance is around, say, 30 and you have for near is 20. So there's a difference of around 40. The near is more than the distance. So then we say that it could be a AC by ratio or high AC by ratio, or it could be a high accommodative esotropia. So we have to do 2 tests. We have to measure the AC by ratio and we have to measure the NPA. And this is very important because it helps us differentiate what type of esotropia we're dealing with, which is having a near which is more than distance. So NPC, the near point of convergence, we have to check a simple instrument like a RAF rule, which we all have in our clinic. We can determine what is the NPA status and also the NPC. So the gradient method is used for AC by ratio measurement, where you measure the AC by ratio is the near deviation, that is the deviation with the lens, with the +3 diopter lens. So suppose, for example, its near deviation is 30 and for the near deviation with the +3 lens is 10. So like we have a 20 by 3 or a 6.6. So the normal range of AC by ratio is between 3 and 5. So we say here is a child or a patient with a high AC by ratio. So then we have, what is the treatment? So now you're like, this child has ortho for distance, but for near, the child goes in. So we need to give bifocal glasses. So bifocals are given for both for high AC by ratio and also for NPA, where we find that it is a hypoaccommodative state, we may have to give bifocals as a treatment. So the minimal lens power that is converting an esotropia into an esophoria is prescribed. So you may start with +2. You can even start give around +2. You do not always have to give +3, but it has to convert an esotropia to an esophoria. It should bisect the pupillary margin because most of the time they're used to making executive glasses where it is at the lower limbal margin. So we need to tell them that this is a child with squint and we need to bisect the pupillary margin. The executive glasses have to be made properly. Otherwise, what happens is that again the squint is there and what the child loses is, for near, the child loses the binocularity. So this is another type of non-accommodative convergence excess with a normal AC by ratio. So what this patient has, you have 30 for distance, 50 for near. You measure the AC by ratio, it's normal. That means with the +3, the squint is still the same. That means this is a convergence excess type of squint of esotropia, non-accommodative convergence excess. And for this, either you do a bimedial recession for the 50 for near, or you do a Fardin surgery where you do a recession for the distance and you do a fixation, posterior fixation suture like this with a non-absorbable suture, 12 to 13 millimeter from insertion. So here you have a preoperative where you have for the near, there is a deviation, for distance deviation and a near there is, and then you do a Fardin and this is what the result you will get. The other type of non-accommodative esotropia is an essential infantile esotropia syndrome where the prevalence is 1 to 2%. So they have a large angle deviation. We don't have to search for them in children. But they present with a small refractive error less than 2. So the important thing is when you have this child like presenting with cross fixation. So now when we have cross fixation in this, we are happy that, oh, this child has equal vision and no amblyopia. So if you give a target to the right, he'll fixate with the left eye. And if you give a target to the left, he'll fixate with the right eye. This is called as cross fixation. It implies equal vision. Now you can see that there is also an abduction deficit, but this is not a 6th nerve palsy or a Duane's. So how do you rule that out? So you rule that out by doing a doll's head maneuver, or you check how much is the abduction deficit when you do a doll's head maneuver. So in this case, that's how you rule out a 6th nerve palsy or a Duane's. But in all these cases, atropine refraction is a must. You need to correct the refractive error and you also need to correct the amblyopia. See, this child is resisting occlusion to the left eye. So we know that the right eye is amblyopic, so we need to patch the eye, do 50% of waking hours if the child is less than 1 year, and you patch and call them you can call them every week or every 2 weeks, just to ensure that there's an alternating squint which is happening, and you check for the fixation preference. Now the controversy is, do we do early surgery? Ultra early in India, most of us are not getting children so early. So we do, for us early is either by the age of 1 year or before the age of 2 years. So early surgery does give you a better sensory outcome. And what also I notice is that when we do early surgery, children are less prone to develop dissociated vertical deviation. And that is something which, again, if you do infantile esotropia later, this is what happens. They keep coming in and then you have to do another surgery for that. But when you do a bimedial recession in a smaller child, you need to measure it from the limbus. Small or a medium or a large, you depend on how much of prism diopters you have got. But we need to follow up these children because they can have consecutive exotropia on follow-up, because it may be the other eye may be the dominating eye. So either if it is more for near, you would do, or a slip muscle, you would do a medial rectus, you advance it. If it has been recessed to around 4 millimeter or 5 millimeter, you can pull it forward, or you do a lateral rectus recession. But always we need to also check that accommodative esotropia following congenital esotropia is around 28 to 65%. And this is why we need to do a cycloplegic refraction on their follow-up visits every 6 months and check if they have an accommodative component, if there is a residual esotropia and they become okay with glasses. We also need to follow up to check for any oblique overactions. Here we can see that a child operated for esotropia, now presenting with a V pattern, or maybe it was not touched and not seen in the first visit, and we have not operated, and now the child is presenting with a V pattern and so loses its binocularity. So whenever there's a V pattern with inferior oblique overaction along with medial rectus recession, we need to touch the inferior oblique. We can't leave them like that. We have to touch them. And also if there's a superior oblique overaction, like in this case with an A pattern with esotropia, we need to touch there's a superior oblique overaction. We need to touch the superior oblique, do a posterior tenectomy of the superior oblique. The other type is an acquired basic esotropia where it is equal for distance and near. Either you can do a both eye medial rectus recession or a recess resect procedure. Both works equally well in these conditions. Cyclic esotropia is a rare form of non-paralytic strabismus with onset at 3 to 6 years of age. They are characterized by esotropia. I have seen 3 such cases, and the cycle varied from 1 week, maybe 241% had at 48 hours, but we need to do surgical treatment in these cases because they go into constant strabismus. The other variety is the acute comitant esotropia. There is type 1, type 2, type 3. Type 1 is the swan type, where after monocular occlusion or loss of vision, they have the esotropia. The type 2 is the Burian-Franceschi type 2, where without any preceding disruption of fusion and not associated with any refractive error, they develop an acute comitant esotropia. And the type 3 is the Belchowski type associated with myopia. This is predominantly seen in young myopic adults. And if the myopia is more than 5, is less than 5, we normally get this esotropia, which is more at distance and then slowly at near. It's mostly seen in children when you have a lot of intensive near work and you have not corrected their myopia. It's an uncorrected myopia. Then you have the acute esotropia of neurological origin, like an Arnold-Chiari malformation, hydrocephalus, or intracranial astrocytoma, and other brain tumors. Now, this was a male child, a 7-year-old male child presenting with a sudden onset of inward deviation of eyes. There was blurring of vision for distance and vertigo. He had a diplopia and since 1 month, and the parents were really troubled. He had vision of 612, large angle squint, esotropia, did an atropine refraction. He had a plus 6.5 to plus 6.5 hyperopia, but which had not been corrected till 7 years of age. But even after correction with the plus 6.5, we found that he still had diplopia and he still had with the glasses 50 prism diopters for distance and near. It was a variable angle. So what I prescribed Fresnel prism for 2 months just to see, like this is like PAT, a prism adaptation test, to see that how much of the esotropia is there to do surgery. Like you want to know the adaptive angle at which we want to operate, because then the patient is starting seeing single with prisms. Okay, we can do an adjustable, but you also need to know how much is the adapted angle, and you have waited for 1 or 2 months and then you operate. Then the child, after the adapted angle for 2 months, we did with the Fresnel prism, and when he got single vision, we operated him and he's ortho with the glasses. Now this is how he's after 1 year with ortho and no diplopia and good binocular vision. This is another 9-year-old which presented with sudden inward deviation of eyes, blurring of vision for distance and near, binocular diplopia. And again, what we found that the child had a sudden change of school. She had not comfortable with the new school, missing her old friends. She had a visual acuity of unaided of 636, and near vision was then 24. Pupils were not myotic, but there was large angle variable esotropia from 35 to 80. Retinoscopy showed variable myopia up to -4 to -5, and on dynamic retinoscopy showed a accommodative lead up to -4 diopters. So did an atropine refraction, no myopia, so that was a pseudomyopia. Vision did not improve still. Still there was esotropia and diplopia. Got a neurological investigation done. Contrast enhanced MRI of the brain and orbit was normal. So we came to a diagnosis of accommodative spasm or the spasm of near reflex. Advised atropine 1% eye drop twice a day for a month, gave also bifocals, and atropine tapered to once a day after a month, and then again reviewed after 2 months. But still the vision had not improved, and still there was esotropia and diplopia. Referred to the binocular vision therapy clinic, and then along with accommodative facility exercises, relaxation exercise with the flipper, and it after 40 sessions of these exercises and also improving the fusional divergence therapy. So the patient became, the vision improved, became ortho with small amount of esophoria for near, and slowly we could, by 1 year, we could remove her bifocal and prism. The other type is a consecutive esotropia, which is seen after the lateral rectus recession has been done. So mainly you wait for 6 weeks and then you either do an alternate occlusion or you can give base out prisms, or you do a surgery if it is still persisting. So already Dr. Kavita has very nicely demonstrated how you do a force duction test, rule out a paratic and a restrictive squint if there is a limitation in abduction. So this is a chromatic 6-nerve palsy. You can see that there is concomitant esotropia. You can see that there is a limitation of abduction. And this, you do a Hess chart, as she nicely demonstrated this here. You can see an underaction of the lateral rectus in the right eye and overaction of the medial rectus. So we performed a surgery of a partial VRT with posterior fixation suture with a medial rectus recession, and the patient was okay. So, but if you have to wait for 6 months, you could try Fresnel prisms and glasses. The other restrictive is the Duane syndrome, where you have limitation of movement. There is esotropia. You have here, you can see that there's severe globe retraction, upshoots and downshoots. This child could just be corrected with glasses. Or you could plan a surgery for the esoduans, where in this case, you just did a medial rectus recession, and sometimes with a large amount of esotropia, you may add on a superior rectus transposition. Coming to my last case, where parents always ask, is refractive surgery an option in refractive accommodative esotropia? I would say a big no, because I have seen in this child where they have done LASIK in this child for the accommodative esotropia for the hyperopic element. There was a corneal epithelial growth, irregular flap with corneal haze, and the squint was also present and led to a very bad irregular astigmatism. So please let us not touch these children. Let them go in the natural course of glasses and getting good binocular vision. So what about in adults? Although hyperopic error diminishes and a fusional divergence amplitude large enough to maintain orthophoria or a well-controlled esophoria develops in most patients, sometimes it does not happen. And then we could offer them adult cases, you could offer them LASIK, especially if the diffraction is less and we find that the topography is normal. We could offer them LASIK for such cases. Thank you so much for a patient hearing.
Thank you so much, Dr. Suma. Wonderful presentation. I would now request Dr. Jitendra to please start sharing his screen.
Is my screen visible, ma'am?
Not yet. Yeah, now it is.
Okay.
Yeah.
So at the outset, I would like to thank Professor Sunaina ma'am and MOS for giving me this opportunity to present on intermittent exotropia. We would, in the presentation, we would begin with first understanding the intermittent exotropia, and then we will move on to the classification, and then to the treatment part of it. So intermittent exotropia, we all know that it is also known as a moving target, because there is no definite fixed target in intermittent exotropia. To begin with, we should understand that intermittent exotropias can start as early as 1 year. This particular photograph is just to show that there are infantile exotropias also, just like infantile esotropias, but they are quite rare. But we should keep that in mind whenever we look for intermittent exotropia, and we would see how we can differentiate intermittent exotropias from other type of exotropias. So this is a wide range of what the whole exodeviations take care of. We would be mainly discussing about the intermittent exotropias, and somehow we can also understand more about how the whole journey of exophoria goes into intermittent tropia and goes into exotropia, which is constant exotropia. Now, to begin with, I would also say that all this classification, we have to understand that this has been man-made just for the sake of understanding. Intermittent exotropia means that the deviation, which is exotropic, occurs intermittently. However, it makes a huge difference as to what exactly is the fusional status of the patient. So some of the patients may have exophoria when you examine them at some instance, and may have intermittent exotropia at the next time. So it all depends on the fusional convergence, because we all know that convergence can be of different types. We will take care of that in the coming slide. So as I said, that you can see in the upper photograph, this is the dissociated state, and the lower photograph shows the fusing state of the patient, and this is constant exotropia. So there is a difference. Whenever we say intermittent exotropia, we mean that when patient is presented to us, there is no manifest deviation. As you can see in this particular case, you can see that the left eye is out. And when we cover the fixing eye, left eye comes in the center, but the moment we uncover it, it goes back. So this is left eye constant exotropia. Intermittent exotropia, we saw this. This is the dissociated state, this is the fusing state. So there has to be a fusing state for classifying it as intermittent exotropia. Now, before we embark on the intermittent exotropia classification, we should understand that we have 4 types of convergence. We all know that from our theory, that is tonic convergence, proximal convergence, accommodative convergence, and fusional convergence. However, the most important, because proximal convergence and tonic convergence, we cannot control. They are not voluntary. Accommodative convergence, again, we can control by giving glasses, and we can control it by measuring AC by A ratio. But fusional convergence is something which is voluntary. It can be changed. So that has to be measured. Whenever we talk about fusional convergence, we should always try to measure the convergence amplitude. There could be a wide range of fusional control. It is possible that patient may have an immediate vergence recovery. Whenever you do a cover test, there can be a delayed vergence recovery. There could be recovery after multiple blinks. The patient blinks multiple times, and only then patient is able to make it straight. And sometimes the patient may dissociate easily with no recovery at all. Now, this is the amount of control that the patient has. Now, you can see that this particular patient does not show any deviation in the primary position. And then when we try, and in this particular patient, we would try to see how to measure the fusional amplitudes. Now, when we want to measure the fusional amplitude, we have to introduce base out prisms. An easier thing is to put a base out prism, use a prism bar for this. You can see we are putting base out prisms so that patient diverges the eye and the eye goes out, and the patient has to bring the eye back. We have to keep on increasing the prism till the point where patient says that he's seeing double, or you can see that his fusion has broken. Now, the point at which he breaks is known as point of, see, you can read this. The point at which his fusion is broken is known as breaking point, and the point at which it recovers is known as the point of recovery. Again, the first and foremost test, as we saw Dr. Kavita's presentation and Suma Madam's presentation, is that we have to check the patient for refractive error. Any anisometropia, any significant emetropia has to be corrected. Normally, we would give reduced hyperopia for the management purpose. But if we are planning to operate, then we have to give the correction. Over minus I personally don't give over minus, but you can give over minus, but that is again only for management. When you're planning to operate, you have to give the patient adequate prescription, and astigmatism should always be corrected fully. Now, this is a small example of a girl who had, you can see that she has exotropia in the photograph. She had intermittent exotropia and a low vision. When we gave her cycloreflection, she became orthophoric. And now we come to the distant near relationship in intermittent exotropia. You can see varying aspects as you can see in esotropia. There could be a distance deviation which is equal to near deviation, or it is possible that the distance deviation is more than near deviation, or it is possible that the near deviation is more than distance. Now, why I have written it in red is because of this. Because there have been two major classifications which are proposed by Burian and Professor Kushner, under whom I got trained. So Professor Burian had a simple way of telling things. Basic exotropia means distance is equal to near, which is similar in Dr. Kushner's classification. And Professor Burian says that it could be divergence axis or it could be convergence insufficiency, where the near angle is more than distance angle. And in divergence axis, the distance angle is more than the near angle. In convergence insufficiency, the near angle is more than the distance angle. And then he suggested pseudo-divergence axis, where if you do a Marlowe's occlusion test, Scobie-Marlowe's occlusion test, you will find out that if it is because of tenacious proximal fusion, you will get equal amount of deviation for distance and near. And another type was known as simulated divergence axis, which was +3 diopter test, where if it is a high AC by A ratio, you would be able to see that distance is equal to near once you correct his AC by A ratio. Now, these are some more classifications by Dr. Kushner, where it could be low AC by A ratio, but it could be more for near than for distance. And this was originally taken into convergence insufficiency. Now, this is only for the understanding part of it. It also helps in management. We will see in the later slides, how does it manage in surgical considerations. Before we embark on any surgical consideration, we should see for two most important things, whether there is any lateral committance, which means that reduction of exotropia by at least 10 diopters or 50% in the right gaze and left gaze, and or if there is a pattern which could be because of oblique muscle dysfunction. And if there is a pattern because of oblique muscle dysfunction, then we have to operate oblique muscles simultaneously. And if there is no oblique dysfunction and still there is A or B pattern, then we have to displace the muscles. Now, this is a small example where patient, when he looks on the right side, has a smaller exo compared to when he looks on the left side and in the primary gaze. What we have to do is, if we are planning to operate bilateral lateral rectus recession, we would be doing slightly less lateral rectus recession on the right side, which means on the right eye. These are some of the examples of A pattern exotropia, V pattern exotropia, where there is infraoblique overaction, and we have to take care of both eye infraoblique, and in this case there is a supraoblique overaction, and we have to do an appropriate oblique supraoblique surgery. Now, when to operate? I think more than anything else, this is the most paramount question which is asked among strabismologists. So the points which I have mentioned are taken from Van Noorden. What he says is that when you feel that the amount of deviation has started increasing from the previous record, when you see that the patient's control is reducing, when you see that the frequency is increasing, which means that the number of time patient used to break earlier has increased, then you can operate. And or if there is loss of stereo acuity and if amblyopia is setting in, then you should think that it may be happening that when the patient is in the clinic, you are able to see that he is able to fuse, but when he is not with you, the patient may be breaking. So there is a Newcastle scoring system which is there, and this is the revised Newcastle control score, which may be a good guide because it basically makes two things easier. You can have a home control and a clinic control. Basically, in the Newcastle revised system, they have added the third category, where in clinic control there was only 0, 1, 2, and now it has got 0, 1, 2 and third thing. So if the score is more than 3, the Newcastle control system says that we should be operating the patient. Now, this is if the patient is having basic deviation, the angle on which to base surgery is measured after the full correction is won. So once the patient is wearing the full correction, we have to measure the deviation, and then he has to be measured at a distance of 6 meters full dissociation has to be taking place, which means we have to make sure that patient is able to Hello, am I audible?
Yes, yes.
Yeah, so before surgery, we have to do a patch test so that patient is fully dissociated and we get the full amount of deviation, which means we should be able to measure the constant exo as well as the phoric component. This is a small device which we had made mainly for when you had seen in the presentation of Dr. Kavita that she has to hold the prisms when the angle is very large. We have to hold 2 prisms, and this is a small device just to show that it can the patient can hold the device and the large angle can be measured. So we have to, some further strategies for basic deviation is that we have to make sure that patient looks as far as possible, use hyperopic correction if it is indicated, and we have to do full dissociation of the patient. Now these are the surgical considerations. This is just a basic guideline. If the deviation is more for distance, we have to do both eye lateral rectus recession. If it is a basic deviation, we can do a unilateral recession resection, or we can do lateral rectus recessions. In my hands, unilateral surgery works better in basic patients. And if it is more for near than for distance, we can still do unilateral surgeries and do a less lateral rectus recession and more of a medial rectus resection. So when we take into consideration the surgical consideration, we should always aim for a slight overcorrection for better and long-term stability, provided the age is more than 10 years. And if there is a lateral incompetence, we should reduce the amount of recession on that particular lateral rectus. Whenever we are doing surgery, we should always try to free the lateral rectus from the infraoblique. And if the deviation is more than 45 to 50, we can either stage the surgery or add a third rectus muscle of the contralateral eye. So that is regarding the intermittent exotropia.
Thank you so much, Jitendra, for this overview of intermittent exotropia. Now, since nobody is going to ask me, I'll start sharing my screen because I am the last batsman in. And after such distinguished speakers, I hope I can do justice to my talk. Just give me a moment, please. I think it's opening. Yeah. So I will be speaking on refraction and strabismus, which, as all the speakers before me insisted, is the way to get it right in strabismus. We cannot think of strabismus without refraction. The refraction has to be correct. It has to be right, appropriate for the patient. And of course, it is necessary to refract because it is very important. And any evaluation of a strabismus case is incomplete unless you refract, because you don't get an idea about it. It can be extremely challenging also, but at the same time enjoyable, because I enjoy doing refractions. And I personally feel that each patient's refraction is different and each patient teaches me something and goes. And I've always felt this way from the time I think I started my career in ophthalmology. But every ophthalmologist has a different take on it. Some ophthalmologists hate refraction. They prefer to go by autoref. I personally don't use the autoref even today. I think I am a better refractionist than the autoref. But there are certain common guidelines which have been laid down by the AIOS, thankfully, which we can adhere to when we are doing refraction of a patient. I'll divide my talk into 2 parts, refraction in children and refraction in adults, because both are equally important. Refraction in children, as Suma, Kavita and Jitendra all said, can be very, very challenging because of many reasons. Because they have a very strong accommodation and they are often uncooperative. In fact, most of the times they are uncooperative and you have to learn how to deal with them Also, they have a very dynamic ocular system because they are growing. When should you refract? Early refraction is always indicated in symptomatic cases, means in those who are showing symptoms of strabismus and in certain clinical settings, which we'll discuss. Otherwise, ideally, diffraction should be done in all children before school going age, that is 3 to 4 years. This is my take. But for this, parents and pediatricians need to be sensitized. And in fact, this year I had it in mind before the COVID took over that I wanted to do a survey of the vision in school-going children in the corporation schools. Teaching the teachers how to check the vision of the patients, which I thought could be an ongoing project for every year. Every year the child's vision could be checked and we'd have a record. But unfortunately, COVID took over and this had to be aborted. Now, people ask what cycloplegic to use. Atropine, of course, especially in esotropes, because you want to bring out the complete refractive error and the accommodative part of it. You can also use hometropine and cyclopentorate in certain circumstances. We'll see how further. This is a table showing the age-appropriate cycloplegia. So if there is presence of esotropia till 5 years, atropine 1% ointment. If more than 5 years, you can choose between the three. If there is no strabismus, then again you can choose between the three. It depends. Atropine 1% is the first choice in esotropes less than 5 years. Please do not deviate from this because it is necessary to eliminate the accommodative element totally. If you don't do it, you may miss out on part of the accommodative element. The ointment should be used in rice grain size 3 times a day, 3 days prior to refraction. And the drops are avoided generally because of systemic absorption and the side effects they can cause. The side effects of atropine ointment, which you must tell the parents about, because otherwise you'll get a call in the middle of the night that this has happened to my child. What do? You prescribe the drops and the ointment, and this is what has taken place. There can be ocular side effects like contact dermatitis of the lids, allergic conjunctivitis, keratitis, and raised intraocular pressure, and systemic such as dryness of secretions, fever, skin rash, irritability, tachycardia, and convulsions. Of all these, fever is the most common, followed by contact dermatitis and allergic conjunctivitis. With hometropine also, the side effects are almost same but less severe. Cyclopentorate drops also can cause side effects like irritation, lacrimation, allergic blepharoconjunctivitis, conjunctival hyperemia, and increase in intraocular pressure. Systemically, they can cause irritability or drowsiness, ataxia, disorientation, incoherent speech, restlessness, and visual hallucinations. So as I said, please pre-warn parents about all these. Don't go into too many details because otherwise they just might refuse to get their child refracted at all. But tell them that this could happen, so please don't worry. This is how you should be prescribing spectacles. The minimum refractive correction to be prescribed in infants and young children. Now, all this data has been collected by AIOS in Indian circumstances. So this is something that we can follow. I won't go into details of this because this is available on the net. Any one of us can go there and see. Now, how to prescribe spectacles? After you assess totally, then you do an appropriate correction, seeing the acceptance of the child also. The child should want to wear the glasses and not just shake them off, because then it serves no purpose. You're giving the correction. In special cases like pseudophakics, aphakics, you must prescribe spectacles immediately as per the retinoscopy. Less than 2 years of age, only give the near correction because the child's area of interest is only nearby. Later on, you can give executive type bifocals. In Down syndrome, ROP, you should prescribe as early as 6 months. And in intermittent XD, as told by Jitendra, myopia correction as per the table, you can do a slight overcorrection up to minus 0.5 for more than 3 years. In esotropia, Hyperopia more than or equal to +1 diopters, overcorrection can be possible. Bifocals must be given in high AC/A ratio cases. You can see how the glasses are prescribed here. The lower slide is not very visible. But now one question which always comes to mind, which I think Suma also said, was what do you tell the parents in accommodative esotropia? Because when the child wears the glasses, his squint is corrected totally. But as soon as he removes the glasses, the squint comes back. Now they want to know what to do about that. So you have to explain to them that this kind of squint is going to be corrected only with the glasses and there is no need of surgery. Sometimes it is more difficult to convince such parents rather than those who actually require surgery. I find it easier to go in for that rather than explaining to such parents that there is no need of surgery. And my final word on that is, it is always beneficial for me if I do surgery. So believe me when I tell you that the child doesn't need surgery. These are some practical tips which I think I've gleaned over so many years of experience. One is, the first and foremost and very important, don't keep your vision chart on till the child is seated and one eye is occluded. Why? Because they memorize. They memorize the chart and then they apply it. They memorize it with one eye and then they apply it and then you get totally confused. This has happened with me. I've already mentioned it in other fora, so I'm not going to say it again. But I totally missed out on one child's refractive error and then they went to an optician and he found it. They came back to me. You can imagine how ashamed I felt when I discovered that he actually had a refractive error and he was pulling a fast one over me. Also, make sure that the child's head is straight and he's not peeking over the trial frame. They always tend to do that. There should be no prompting from parents. Parents, feel, the child is not reading. Oh, can't you see it? Oh, that's a E, that's a U. So, if necessary, tell them to go and sit in your waiting room so that they cannot interfere in your examination. In amblyopia, please explain clearly to parents what needs to be done. I have found very often with many of my colleagues as well that they don't tell the parents about amblyopia. They feel that if they tell, the parents will get scared, and they'll run shy. But who is going to tell them ultimately? Somebody has to do the job of telling the parents that your child has amblyopia and it needs to be treated. So why shouldn't you be doing it? And once you explain, I think they are all for it because they want the child's vision to improve. This is just a small video showing you how children can behave. Just see. And for your information, as I told my colleagues yesterday, this is my granddaughter and that's why she's behaving so badly. She's my worst patient, actually. And look how nicely she's putting her hair up so that I can put the trial frame on. None of my other patients would do that. And then just look at her peeking and peeping over and below the trial frame. She just will not read. I'm saying she's my worst patient ever. I can handle all other children except her. Now we come to refraction in adults, which is a totally different ball game altogether because they are cooperative. They can read and they can follow instructions. Hard work in them. But still, there are some things which you need to take care of. These are a few pointers which I would like to emphasize on, that always remember, do a dilated retinoscopy. Don't do shortcuts, whether the patient is emetropic, myopic, or hypermetropic. Do a dilated retinoscopy. It is very important. And please do not rely only on auto-ref readings. They can be widely wrong. I have seen that for myself. In my own case, my refractive readings were wrong. And get the feel of the patient. You cannot tell over the phone to someone that you prescribe this for your patient, because at least I don't get the feel. Until I get the feel, I cannot prescribe. And after a lot of experience, your own sixth sense guides your hand to the right lens, which also I have found in most of my cases, that my last reading, the last lens that I place, and the patient says yes to that, there's hardly a difference of 0.25 or 0 between the first lens and the last lens. In hyperopes, I would always recommend prescribing glasses after fogging. I don't know whether many of the newcomers even know what fogging is, but if you don't, read it up and never prescribe without fogging. I don't do it ever. Explain clearly to the patient's relatives or to the patient that the refractive error and the strabismus are two different entities, though they are related to each other. Very often, as I think Kavita said, parents will say, okay, the refractive error will go away. No, it's not going away. It's there. We are only correcting the strabismus when we are operating or we are giving glasses. We are not correcting the we are correcting the refractive error, but it's not going anywhere. It's there to stay. So correction of the squint is not correction of the refractive error. This applies to kids as well. You have to tell the parents there. And emphasize, please, that the spectacles need to be worn even if you have given minus 0.25 or minus 0.5, whether spherical or cylindrical, but the glasses need to be worn full time. And of course, treat the associated amblyopia as is required. I'll just quickly go through two cases which I thought of showing to you. This was a 10-year-old boy brought by his father to me in 2015. There was a history of squinting in the right eye since the age of 6 months following an attack of dengue fever. On examination, the uncorrected visual acuity right eye was 6/12 partial, not improving. Left eye was 6/6. After fogging, this was the acceptance, +1 right eye and +0.5 left eye. The XT was right eye 35 degrees. There was an A phenomenon, and Hirschberg showed a PBCT 75 prism diopters for near and distance. Same. The diagnosis was right eye XT 35 degrees with mild amblyopia. I would label this as mild amblyopia. Now, because this family was an educated family, the father was very cooperative and they were willing to go in for treatment, I did the amblyopia treatment first. So I advised occlusion of the left eye for 2 hours every day, 6 days in a week, followed by 1 rest day for 6 months. And the eye improved to 6/6 partial, the right eye. Then after that, after 6 months, I did a right eye medial rectus resection, 6 millimeters, and lateral rectus recession, 10 millimeters. And I maintained the occlusion for 3 days per week. When they came back to me, there was just a residual squint of 5 degrees with a PVCT 10 prism diopters base in. So I didn't told them there's nothing needs to be done. 5 degrees is nothing. Now, the second case was a 26-year-old girl. As we all know, most girl cases are brought to us at marriageable age. This is probably one of the same things. She presented with alternate squinting both eyes since the age of 2 years, and on examination there was alternate XT both eyes more than 45 degrees, and the prism bar cover test showed 95 prisms base in for near and distance both. Uncorrected visual acuity both eyes was less than 6/60, and best corrected visual acuity both eyes was 6/6 with refraction, which was -12 diopters both eyes and -10 diopters for near. This is what I gave her. And I did a both eyes MR resection 6 mm and LR resection 11 mm at the same sitting. And there was full correction after this. I would like to acknowledge the AIS focus group with whose help I have made this presentation. And of course, I want to acknowledge my patients who have taught me strabismus, I think, on the go. So here's to a corona-free world, and thank you all so much for listening so patiently.
Thank you, madam, for a lovely talk.
Thank you, Nikhil.
I think it was very, very explanatory and very comprehensive. And I think you came out with very, very important practical tips that only the book called Experience can give all of us.
Thank you.
So thank you so much.
Thank you.
So if anyone, I think
I can take them from any of us, any of the panelists.
Dr. Kavita, may I ask you one question, if it's fine? So you mentioned, about the sensory evaluation. Could you please explain a little bit more about distance stereopsis, how it is evaluated and its significance, and how it helps in timing the surgery for IXT?
Yeah, so that's a actually important question. I kind of intelligently ignored it because in our routine practice, we don't use distance stereopsis tool, but yes, for intermittent divergent squint, near stereopsis is retained for a very long time actually. So ideally, one of the criteria to manage an intermittent divergent squint surgically depends on the distance stereopsis, which is measured by a lot of the instruments which used to measure distance stereopsis are more cumbersome and big. So we actually do not in our institute routinely use it, but instruments, but it's part of intermittent divergent squint management. Part of it has to include a distance stereopsis assessment. The BVAT machine and all that is used. But we do not use. I would ask any other colleague who practically use intermittent stereopsis methods if they have in their routine practice.
Yeah,
but
no,
I agree that.
Yeah, right. No, I saw it. I saw the Frisbee Davis 2 used quite elaborately at RP Center. Dr. Pradeep Sharma really depends on it quite a lot, and I think it is the ideal pointer. I mean, you don't want the stereopsis. The next step would be the near stereopsis that's going to go. So I think it's a really important. Dr. Jitendra would probably elaborate when.
Yeah, there are two things I would like to add. Am I audible?
Yes.
So the first and foremost thing is that, intermittent, when we are measuring, we do measure, since this was more of a basic presentation, I would say that distance stereoacuity is important. There's a few things which I had also not included because presentation was already very big and I had already overshooted my time. One of the most important thing which I had not included was convergence exercises, pencil push-ups, because that forms a very important part, but I completely did not include the non-surgical management of intermittent exotropia. Regarding distance stereoacuity, I think it is a wonderful tool. It is not really cumbersome because it's very, if you have Frisbee Davis 2, it is fine. If you don't have it, what we can easily do is, I'm just suggesting, we have done it, we have done a trial also. What we can do is we can test you can take a photograph. Now this is unofficial. I mean, I'm just giving a tip. Yeah, so you can take a photograph of TNO chart. You can put it in a projector, or you can just, now that we have got visual acuity, we measure with a computer system. So you can just project it through that computer system, and you can wear red-green glasses, and you can ask the patient. Now the only question which arises is that how much is the stereoacuity? Now what you can do is, since the original chart was made for 40 centimeters, you can divide the distance, the actual distance which you are having, you can measure it proportional to that. Now the original stereoacuity is for 40 centimeters. You can measure the distance between you and the chart, and then according to the ratio proportion, you can easily find out what is the distance stereoacuity based on this. Now we tried to compare Frisbee Davis 2 with this TNO projection system, and we found that the stereoacuity was low when we compared with TNO. As such, also TNO is a highly dissociating test because both the red and green glasses are on right eye and left eye, and we have total dissociation. So we find that Frisbee Davis 2 is more physiological, but then, and it would be even more important, especially for intermittent divergence axis, intermittent exotropia, because these patients already have a very flimsy stereoacuity. So I think you can do it, but the only difficulty is that it is difficult to quantify for distance what exactly is normal. Although books say that 100 seconds of arc is normal, I know, but then in practical purpose, the distance, if you vary the distance, it would change completely.
Right, right. I think that is really interesting. I hope you got a patent. You took a patent for that, Dr. Jitendra.
No, actually,
I'm just joking. I think it's really nice. It's really interesting what you've done.
It is actually from TNO. So the original patent holders are TNO. We are actually using their images. So I cannot officially I cannot suggest this. But
I was just joking.
I can tell you that.
Absolutely.
We use it in our clinic only. We don't tell. I mean, we don't propagate it.
Snehal, any question from you?
May I add a point?
Yeah.
Yes.
Sure.
Yeah. So in the same context, like since distance stereopsis measurement is not kind of routinely being done, we kind of use the deviation, the amount of percentage of deviation which is manifest for distance, like making us the amount of deviation or amount of the frequency with which the deviation occurs. If it is more than 50% of the waking hours, more than 50% of the daytime, then we kind of have to assume that it is the distance stereopsis must be compromised and kind of we advise surgery rather than waiting. So
right.
About intermittent exotropia, I take it.
Yeah, that's a practical way of doing it. Yeah. Sure.
There's one more question. Someone has asked it. Give us, can you just, how to measure AC by ratio again?
Yeah.
Actually, I think
I already mentioned in my presentation.
The gradient and the hydrophoria method.
Yeah, so basically use the gradient method. Simple method is a gradient method. Like, so if you find a difference in distance and year, then after you do that, after you're putting your correction for the distance, then you put another +3, and then you measure again the +3 lens for near. And then you see, so then you can measure it is like, because then you can take the formula is the deviation with the +3 lens and minus the deviation for near deviation, and then you divide it by 3.
Yeah.
So, and that's how you measure it. Then you can get, this gives you a rough estimate of the of the high AC by ratio.
Yeah.
Heterophoria method is not used because most of the time it overestimates. So if you find that most of the time it overestimates your AC by ratio, gradient method is what most of the people
are done in all the clinics. Yeah. Suma ma'am, may I just ask you about what is your opinion about Botox? Nowadays we hear a lot of people giving Botox even in infantile esotropes. I find it really difficult to digest because people are talking about giving Botox instead of surgery, or some are also talking about giving Botox along with medial rectus recessions for infantile esotropias and doing inferior oblique weakenings at a later stage. So your opinion on that, please.
I personally don't do Botox in infantile esotropia. Of course, in a 6th nerve palsy, we do give Botox. Yeah. But in a infantile esotropia, see, best is to, you can measure it before the age of 1 year. Like suppose now, and you can take 2-3 measurements. And I think children are cooperative for measurements. Suppose if they are not cooperative for measurements at all, suppose, and then you want, because then you want your, that the near deviation does not cause a bad sensory outcome, then maybe I think it could be sensible in a child where there's a variable deviation, where you're not able to measure the deviation. Maybe you could give Botox, and later on when the child is cooperative for measurements, you can go in again and do a medial rectus recession. But I think most of the children are cooperative, and even if you leave behind 5 to 7 prisms or 5 to 10 prisms of esotropia, if you have undercorrected, you can still, you can cycloplase the patient, give some amount of prisms, after that. And I also give prisms in the classes. Because suppose I've got behind, say I've done surgery and I've still got a residual of 5 to 10 prisms. I would split the prisms and give it in the glasses so that to take care of my sensory output. But I would not, because most of the time the parents are so hesitant for general anesthesia.
True.
See, that is the main part. And then you tell them like, okay, now I'll do one surgery. And then again, I want to do another surgery for your medial rectus recession later. They are not going to allow. For one surgery, always they ask infantile esotropia anyway is a surgery where you have to keep on doing 3-4 surgeries sometimes.
Yeah.
Later, the DVD comes, the inferior oblique overaction comes, your consecutive happens. Now when you are into 10-15 years of practice, you realize all your infantile esotropias who are not stable are coming back with your consecutive now.
Yeah, absolutely.
So managing them later. So multiple surgeries is something which I think we can measure. Maybe for children who we can't measure, we could go ahead with Botox.
True.
But I've
So
heard
when
there
you
are good results. Yes.
Can I just add something here?
no, I just wanted to ask.
Yes.
Okay, when you give prisms, how much do you give prisms post-operatively? How much deviation?
The glasses you can grind around in the glasses. Though you can grind around 6 prisms. Means as sometimes the
3 prisms in each eye.
Yeah, 3 prisms in each eye. No, you can give even 6 prisms in one eye. Suppose if you have a residual of, but you undercorrect slightly, so that some amount of. So basically, what I feel is that you are trying to prevent even microtropia from remaining. But otherwise, you have still microtropia remaining, and that itself also can cause amblyopia. So you're not going to get 100%. Most of the time, you're not going to get dot ortho because your child is less than 1 year. You may have a slight measurement. There might be an undercorrection.
But Suma, do the children adapt to the prisms?
Yes, ma'am. Yes, they adapt. In fact, I have not found problems with. I mean, there's a small amount of prisms.
Yeah.
It's like 4 or 5. I wouldn't give more. If it is more than 15 prisms, anyway, I'll do a resurgery. I will do one more lateral rectus resection. And then I know I have really undercorrected it.
In that respect, I would just like to say something that I always make it a point to tell my patient that there can be a need for a second operation right at the beginning.
Very true. Very true.
Yeah, very true.
Very true.
I have suffered this. I didn't tell one patient, and after the first surgery was over, there was residual squint, and they came after me. They pounced on me. Simply, they said, "Why didn't you tell us before?" I learned my lesson the hard way from that. After that, I always tell each and every patient, even if there may not be a need, even if I feel that I'll be correcting it in one go, but I tell them there could be a need for a second surgery. It's better to have that clear from one.
Yeah, Dr. Jitendra, you want to add something?
Yeah, I was saying that, you know, what I do in post-op patients is that normally these patients, you know, with esotropia, they do have some hyperopic refraction.
Yes, that is true. Yeah.
So what I do is I try to decenter the glasses. We have developed a small technique to decenter the glasses, which is like very easy. You can decenter it very accurately. You can take a slab and you can put it under the lensometer, and you can actually see how many prisms you are, so normal formula, we all know the Prentice rule that you can do it, but you can do it more accurately with the help of prism. You can actually do it under a lensometer and you can decenter it. You can, I mean, it is very easy to decenter and get around 4 to 5 prisms. Yes. Normally that is the amount of prisms we would be giving post.
Even in the glasses,
Yes. Because prisms, if you add in hyperopic glasses, no, they become more thick than already they are thicker glasses because of the base curve. They already have a front curvature. They will become even more thicker.
Yeah.
There is one question from the audience. Dr. Rushabh Shah is asking that he had a patient, 8-year-old who had a -12 diopter before cyclo, and after cyclo went to -6 diopter. Which glasses to prescribe in such a case? And does it also mean hyper accommodation?
Yes.
How to treat such a case?
You mean to say he had
-12 before the cyclo,
and then refraction.
Then after cyclo he got -6.
Yeah.
Okay. So he wants to know what to prescribe, -12 or -6.
So we are seeing a lot of these in the COVID era and increased screen time era. So much.
So who would like?
It's a anyone can. What you're saying, there is no myopia. So being shown in your dry retinoscopy, then what you get. So you have done a cycloplegic refraction and you got less. Then I think you should, in that cases, you should do like a dynamic retinoscopy and see if there's also any accommodation problems. Because if there's an accommodation problem, like mainly for us lead. Basically, you do a dynamic retinoscopy and see whether there is against the rule where you have getting a minus shift. So if there's a lead, then you know that the patient is using more and more accommodation, and then you need to relax that accommodation. Maybe in that patient, as I explained, may need to be put on some say at homide, but I find very less effect with homide. I do put atropine only. Because otherwise you can't relax them. But I would give the glasses with the cycloplegic. Like I would not. I would again
-6.
-6.
Yeah, I would repeat it.
Oh yes, you prescribe whatever is there after the cycloplegic.
But what was the refraction? What was the best corrected visual acuity? with minus
that
and minus.
has not been mentioned.
That hasn't been mentioned.
More often than not, the the BCVA will improve slowly. Initially, it may not be full. BCVA may not be more than 612, but gradually it will improve to 6.6.
Kavita,
Dr. Kavita, please.
In this scenario, I would also do a thorough slit lamp examination. Sometimes not very rarely, we do see children with a subtle subluxation of the eyes and all, which can give an irregular reflex and dilated.
How to do a dynamic retina.
So we would need a thorough slit lamp examination in a dilated state to rule that out, and then to see if it is an accommodation related over correction. Vision should be good in that non-accommodated state. Like if the patient is minus 12 and has good vision, but you reduce it to the actual power, the vision deteriorates. That kind of gives us an idea that because accommodation, there should be a drive to accommodate. So when they accommodate, if they see clearly well, then only they accommodate. So with minus 12, the vision is more or less good compared to minus 6, then it's more in favor of a accommodation issue. And like ma'am said, we do a thorough, we recheck definitely, and then do a thorough orthoptic evaluation maybe. And then if we find accommodative issues, then we treat it with atropine. Like ma'am said, homide is probably not so effective as atropine. And give the minus glasses and not minus 12. We cannot overcorrect.
Yes. Any one tip how to do a dynamic retinoscopy so that people know? Ma'am mentioned dynamic retinoscopy. Dr. Suma mentioned dynamic retinoscopy. So just a small tip, for the how to
basically
go about
in this, it's a dynamic retinoscopy. Many methods. What we do is the MEM method, that is called as the monocle estimation method. So when you are doing a retinoscopy itself, you ask the person to look at the near object because you want to investigate the accommodative state of the eye. So what you will ask the patient, like at near when you're doing the near retinoscopy, and you keep it at a distance around 16 inches, and then you ask them to look at the target, and you keep it, and then but they need to wear their full correction when you're doing a dynamic retinoscopy. You can't do it suppose now you've got an uncorrected refractive error. After you've got a full refractive correction done, then you will ask them to look at the near target, and then you see whether there's a with movement or there's a against movement, and how much it takes to neutralize that. Suppose now there's an against movement, how much it takes, a -2 or a -3 or a -4, how much it is taking to neutralize that movement. So then you know that there is an accommodative, if it's a minus, it is a lead. If there is a plus, you require more plus lenses to neutralize, then you know it's a lag, like the hypoaccommodative. So when there's a lag, like in Down syndrome cases or something like that, they will always have an accommodative lag. So those cases,
normally it should be around plus 0.5, I think.
Normally it should be around plus 0.5. Yes. If it is more than, see, all these CVI children also, you have the children with accommodative lag.
Yeah.
You need to do that in all patients.
Yeah. So what is everybody's opinion here on if there is high AC/by ratio and there is esotropia? So rather than going in for executive bifocals or pupil splitting bifocals, and eventually you end up sacrificing quite a lot of stereopsis, even though you can get the squint under control. So what is the all of your opinion about going in for early medial rectus recessions? Is that an option?
I do not operate in high AC by ratio because I feel that it reduces over time. You can agree that most of the time we are fighting with that bifocal. Mostly the time they come back, it is not bisecting, it is down. I know that it is a struggle. But then if it goes out, then later on, if you have, because you can wean off the bifocals. What will you do in high AC? I've operated very rarely with a Farden, not. Like I would do a Farden, but I'm not in favor of. I would not recommend to anybody, because you have to really follow up.
Yeah.
Because I don't know about Jatendra.
I also agree with ma'am. See, children, especially when they have binocularity, like accommodative esotropes, the good part is many times we can catch them when they are still binocular. So if they have a good binocular vision, correction with bifocals, they really do well. So like ma'am said, every time you prescribe, you have to see them back and see if the glasses are correctly made. If they are made correctly and the deviation is really corrected for distance and near with your bifocals, and they have some near fusion and stereopsis, they do kind of accept it. And it is like after a few years, about more than 10 years or so, you can gradually wean them off. It's a better option. But suppose you have a residual esotropia for distance also, and you are planning a medial rectus recession, then maybe you can add Farden if there is a near deviation, which is more, but not probably the primary option.
Okay.
Dr. Nikhil, you do?
No, ma'am. No, I very rarely did. Just a couple of cases where there was a lot of, the compliance wasn't too good.
Not compliance,
yeah.
I have a question for Dr. Jethani.
Yes, ma'am.
Will you please elaborate a little bit on the non-surgical management of intermittent exotropia?
Yeah, so basically, to begin with, we give glasses and then we try to measure what is the angle. And if we feel that in our own setup, we try to do a small study as to what angles do improve. So in our setup, we found that around 16 prism diopters, if the patient has an angle of less than 16 prism diopters, we try to tell him that, you have a good prognosis with a good chance with convergence, with convergence and binocular exercises. So what we do is when the kid is less than 2 years of age and we know that he cannot do convergence exercises, we start them on alternate patching to do anti-suppression. Once they are above that age where they can, we basically try to make them understand that there are two kinds of exercises. I know this is not truly a scientific term, but it is active exercises and passive exercises. So this is the term which we use to make sure that the layman people can understand what we are saying. So passive exercises is to patch alternate eye, and this actually reduces the suppression because it makes sure that they start actively inhibiting the suppression and they try to see with both eyes, and then probably it can develop some amount of fusion also. And then we tell them to do active fusion, and we start them on pencil push-ups and the dot card therapy. And we also give them stereogram, the CAD cards. So CAD cards, what we have done is we have modified the CAD cards according to our needs. So basically what happens in a CAD card is the actual CAD card was made by the Clement Clark company. And there is a definite distance between the two CADs. What we have done is we have scanned those things and made sure that the two CADs are very close to each other, so that the patient understands what is expected of him and is able to fuse the two CADs. Once he knows that he can fuse it, sometimes what happens is they are never able to, they never even get an idea what is expected of them. They can never see the cat with the ears and the tail. So this is how we do, and we go one step further. Since we have scanned the two photographs, we keep them at a bigger distance also. So once they say that they can use the standard CAD card, we tell them to start using this. We also use gyroscope and dichoptic exercises a lot, even for intermittent exotropes. So we tell them to buy a red-blue glass, which is available on Amazon. It is around 150 rupees. And we try to tell them that they can download the free games, which are also available free on the Play Store. And we tell them that they can do some exercises on gyroscope also. Basically, we try to make sure that we improve their fusion. And if the angle is less, it does help. If the angle is large, we give them an option, but then we tell them that, we try to tell them that this is not going to really help. We are trying to, because convergence insufficiency patients, even if you operate them, there's a huge chance that they will go back. So we try to tell them that they have to do exercises even before surgery. And then we tell them that even if you operate, you have to do some kind of exercises post-surgery also.
Yeah, keep them in the center.
Yes.
Okay. And so there is one question here from Nigeria, Dr. Adideo Adio.
Yeah.
So this one, so it's not related to any of our topics, but it's really interesting. So I think we have to take it. It's about third nerve palsy correction, surgical correction. So he says that even after surgical correction, many times you find the medial rectus to be quite lax. So you do find a lot of residual exotropia even after surgery. Now that is what we've been battling for decades, I think. So he's asked us for tips. surgical tips from the experts. It's a really
Third
big
nerve is a
question.
challenge.
It's a big one, yeah.
It keeps on drifting. So first we used to try medial rectus periosteal fixation. Then again we did a large lateral rectus recession with periosteal fixation. It again drifts. I feel that the lateral rectus periosteal fixation I found it worked much better than the medial rectus periosteal fixation.
Yeah.
At least it is much better than that, and it is less drifting. And the other, now where the splitting of the lateral rectus to the medial rectus, I have just done one. I mean, I've not done many. I've just done one, and I found it to be effective. But in that case, it was very tight muscle, and pulling it. That's why I was talking to Dr. Pradeep Sharma sir also that day. It was so tight, and to bring it to the medial rectus, luckily there was an absent superior oblique tendon also in that patient, which we have now sent it for publication. It was very difficult to pull it. So I was asking sir, like sometimes it doesn't come up to the medial rectus. So he's saying wherever it comes, you put it.
Yeah.
So
how much ever traction you can get, it will be a bonus.
But I was discussing with in Orbis, so they were saying that they have seen some choroidal effusion in some cases. So Dr. Andrea was telling me to be wary of doing this. So she was saying don't make it too tight. So the results are like you have to explain to the patient if it drifts again. I don't know, Dr. Jitendra can answer more. Maybe he has more experience in.
No, I'm very similar to your experience. There's not much third nerve is a difficult, it's a tough nut to crack. Yeah. It's not simple because, you can, all of us have done lateral rectus and then medial rectus, and some of the medial rectus periosteal fixation come back with infections also.
Yeah.
So, because you're taking a non-absorbable suture, and then we have to revise it, and it's a difficult thing. It's a tough situation, and I always tell the patient, see, only one of the muscle is working. We are trying, we may not succeed, and I always tell the patient, see, you can always take a second and third opinion, because it is not something you should stop him from. He should go ahead and explore the options. It is quite difficult to manage.
Yeah.
How long do you normally wait, all three of you, in a case of paralytic squint? How long do you normally wait before intervening?
6 months.
6 months minimum.
Yeah.
Okay.
In that period, Botox can be given or prisms can be given.
Actually, I had a phone call the other day, just a couple of days back, from a patient who is in Karad. I am in Aurangabad, and this is pretty far from me. And he gave a history over the phone of a fall in the bathroom 6 months back. And he got hurt over 1 year and the same eye. And he complained of squinting of that eye plus double vision. So when he mentioned double vision, my ears perked up and I thought it's got to be paralytic squint because he's giving his history of trauma. And it's now more than 6 months. So, and it hasn't resolved. He's shown a couple of places. Everywhere he's been told that nothing can be done. So then I directed him to the nearest person close to him. I told him in this period of Corona, don't try coming to Aurangabad also. Just get seen by someone near you, and she's my student and she'll guide you and she'll give me the feedback as well. So what would you have done in such a case?
Now, first and foremost, we have to see whether it is a traumatic sixth nerve palsy, traumatic fourth, we don't know what the palsy is. It's a fourth nerve palsy, it's a bilateral fourth nerve palsy, bilateral sixth nerve palsy, or it is a third nerve palsy. Most of the time you can have trauma in any of these. So most common, of course, is fourth nerve palsy, what I've seen, traumatic. And so we wait for 6 months, and then depending on the deviation, I would offer surgery to them because diplopia is very disconcerting. So I think after 6 months means we wait for 6 months because we hope for some recovery. But I think after 6 months, most of it can be now corrected, and the patients are quite happy with the correction. Either you do a partial BRT or a VRT, or you can even add on with you can if it's a fourth nerve, if it's an acquired fourth nerve palsy, you can even do a Harite. These patients are happy with the result. I think we should offer them surgery after 6 months.
Absolutely.
One more point. So after 6 months, we kind of, in addition to that, we confirm with 2 visits when the angles are stable.
Yes.
So
Right.
that's understood, but yeah, that's what we want.
Yes,
Dr. Nishita is asking, do you recommend pencil push-ups in 15 prism diopters IXT in a presbyopic female aged 40 years? Pencil push-ups in a 50-year-old.
Dr. Jitendra, that smile was amazing.
See, what happens is with your age, see, what we are trying to do here is we have to understand the whole system of accommodation and convergence. In presbyopic age, we can see there is no harm in trying. I won't say that I won't give it. I would, of course, give it because as a pediatric ophthalmologist and as a strabismus surgeon, whatever is our age, we have to go slow in these things because whenever you operate, you can't undo it. So there is no harm. But most important thing is, at a presbyopic age of 40, what exactly is her problem? Whether it is related to accommodative convergence, because at 40, it is not just fusional convergence. The patient may actually be having a loss of accommodative convergence also. We can give a trial of pencil push-ups. In fact, at the age of 40, maybe we can give even 4 prisms in each eye and then try to tell her that she can do pencil push-ups and when she improves her fusion. But all this is when we check her fusion. One most important thing which I was trying to drive on was we can give pencil push-ups in a patient of 15 prisms exo when the deviation is more in near. See, if the deviation is more for distance, giving pencil push-ups will not help. So in divergence axis, so we have to find out that it is a convergence insufficiency or not. That part I probably, in the jest of telling, I forgot. You can. What we have found out is that you cannot remove the amount of deviation, but you can improve the control. At 40 years of age, you can increase the control, but you cannot completely remove the deviation because the deviation is mediated from the central system. It is not at the motor part of it that there is a problem in the motor aspect and the eyes have gone out. There is a problem in correction of the anti-saccade reflex where the eye drifts out and it completely comes back, but before it comes back there is a lag, and this particular lag is what makes it more prone towards going out. So it is not just that that intermittent deviation is going to be it is different from constant exotropia. So we have to understand that intermittent deviation means that there should be a problem with the fusional aspect of it.
Having said that,
what confused it more.
Yeah, but Dr. Jitendra, we've seen many a times people with 40, 45, 50 prisms of exotropias, intermittent exotropias, 40, 45-year-olds sometimes shockingly control it, and at times they are also. Isn't it?
Because fusional convergence is voluntary. It can be up to 45 prisms also. So fusional convergence is there, but what I'm trying to say is that if they have a good fusional convergence, we can't improve further upon it.
Correct.
If he has a deviation of 50 prisms and his fusional reserve is already at 50 prisms, so we can't flog the horse just because this is the first thing. We have to give pencil push-ups to everybody.
Yeah.
If the angle is too large, I don't think it is going to improve. But yes, we should impress upon them that this may be required after the surgery to build up your fusion.
But then would that happen in presbyopic age? Building up of fusion after surgery, would that happen?
No. Fusional convergence is not dependent on accommodative convergence. It can build up. There is no
convergence, in fact, stays standard throughout life. In fact, it doesn't deteriorate too much like accommodation.
Accommodative convergence. So a part of convergence, as accommodation will deteriorate, some part of accommodative convergence may go down. But So we have tonic fusion, tonic convergence, proximal convergence, accommodative convergence, and fusional convergence.
I think we have time for just one last question. Is there anything, Snehal, that you?
Snehal wants to ask you something, ma'am. I think.
Okay.
Ma'am, any tips for how to for the amblyopic patients? Any tips for refraction?
That is one whole talk, isn't it?
No, just at least.
Yeah.
You know what I would say for amblyopes is always treat them. In my opinion, people say that after a certain age, see, if the child is beyond 10 years old, there's no point in treating amblyopia. He's not going to improve. But I always felt, and even today I feel, why not give the patient a chance?
Yeah, absolutely.
Even if she or he is 16 years old, 18 years old, why not give them a chance to improve their amblyopia if it works? If it works, well and good. I tell them very frankly that, see, we are trying. I am not promising you anything.
Yeah.
We try for 2-3 months. If it doesn't work, we'll stop it. And if they are willing, we go ahead. For children, of course, I emphasize. But at the same time, here I would like to mention something. Once I had a patient who was living across the road from my clinic, just across the road. And he happened to be my student's nephew. And he had amblyopia. Now, all he had to do was cross the road and come to my clinic for amblyopia exercises. And the child absolutely refused. He would not, in spite of his aunt's insistence, his parents' insistence. Ultimately, we had to let him go. There was just nothing we could do. Because his parents told me, we are forcing him and forcing him. He's just not listening. So you do your best and to God leave the rest. I think that's what I would ultimately say. But yes, try your best.
Okay.
Explain to the parents, most importantly, if the parents are with you on amblyopia treatment,
Yeah.
I think it goes a long way. It goes a long way.
It's very important, yeah.
So,
okay.
So I think we are done. We've taken up a lot of time of our panelists, but we've had a wonderful webinar. I think I've loved it because as it is, being among strabismologists is something wonderful.
So it's a glorious speakers, ma'am. We wouldn't have expected anything else. Wonderful. It's fantastic team of speakers.
As well. Two very good moderators who guided the talk so well. And now I would like to request Snehal to give the vote of thanks. But before she does that, I'd just like to remind our MOS members who are listening in that we are having this massive membership updation drive. It's on till 21st September. You need to have your membership profile updated. If you lose out on it now, you may never get a chance again, maybe for the next 8 years or 10 years, because this hasn't been done in so many years. I was secretary in 1998-2000. I don't think it's been done before or after that. So we are doing it in a big way this time because of online voting this year. We want all our members to get their profiles updated because it's now or never, believe me. So please go ahead and do it. Only you can do it. We can urge you. We cannot do it for you. So please do it. And our next webinar is going to be on 26 September on our everybody's favorite topic, phaco. So over to you, Snehal, for the vote of thanks.
First and foremost, I would like to thank Malik ma'am and team MOS for organizing this wonderful webinar. Thank you, Dr. Suma, Dr. Kavita, and Dr. Jithani for your part. Without your participation, this would not have been such a grand success. Thank you, Nikhil, for being such a great co-moderator. And I'm grateful for the opportunity, ma'am. And at last and not but the least, thank you, Entod, for all the technical support. Thank you all. Thank you so much.
Thank you all.
Thank you, Snehal. Thank you, Snehal.
Thank you so much, ma'am. Thank you. Thank you, Rishi. I had a wonderful time. Thank you.
Have a safe weekend, all of you.
Thank you, Dr. Snehal.
Thank you.
Thank you, Dr. Nikhil.
Thank you, all of you. Bye-bye.
Bye.
Thanks to the audience. Bye-bye.
Yeah, thanks.
Yeah, thanks.